Hello, everyone, and welcome to the Down Syndrome Center podcast. As always, I'm your host, Dr. Kishore Balodi. Today, we are joined by Dr. Stephanie Santoro, who is an expert in this area that has been really intriguing. Over the past many years, we have been getting lots of questions, and you probably have seen some information coming about this entity called Down Syndrome Regression or Disintegrative Disorder. There's been so many names for it. I'm sure that Dr. Santoro will fill us in on. But before I get too far into the podcast, I'd love, Steph, if you would mind just share a little bit about who you are, what you do, and why you love working with this population.
Yeah, sure. Thank you so much, Dr. Balodi, for having me on the podcast today. So I'm a clinical geneticist. That means I'm a pediatrician by training, and then I've done extra training about genetic syndromes. And so I see patients with Down syndrome throughout the lifespan, and that's one thing that I think is really special. I get to see babies as soon as they're born and be the first one there to deliver this diagnosis. I get to hear and learn about their first steps, and I get to see them into adulthood. So that's really what I love about working in the Down syndrome program at Mass General.
Wonderful. And so what is it that makes you enjoy working with this population so much? Do you have any reason why you've chosen to work with people with Down syndrome?
Yeah, I kind of caught the Down syndrome bug when I was a resident, and I shadowed in the Down syndrome clinic at Cincinnati Children's, and I really just fell in love with all of the patients and have continued kind of throughout my career, really focusing on this area. Yeah.
That's so amazing. That's fantastic. It's yet another example of how people with Down syndrome can impact so many of us in so many different fields. So it's awesome that that's an area that you have found to love. And one area in particular that I know, in fact, we've worked together on a couple of projects now, is this area called regression. But I guess I would start with, okay, first of all, what is it? And what are some other names that people have called it so families may be familiar with what we're talking about today?
Yeah, that's a great question. So kind of historically, the first case report of someone with Down syndrome having this kind of regression was from back in the 1940s by a Dr. Rowland. And the main things that go along with this entity are kind of significant loss in skills, mood changes, and sometimes kind of repetitive thoughts and behaviors. And you're right, it's gone by a lot of different names. It's been called Down Syndrome Disintegrative Disorder. It's been called catatonia. It's been called Unexplained Regression or just regression. And I think we're really kind of getting close to the point where we could find one name to call it. But, as clinicians, we're all kind of seeing the same thing in a lot of our patients.
And do you think, is this something new, or is this something that's always been there that perhaps has been misdiagnosed, maybe early Alzheimer's, things like that? What's your thoughts on that?
Yeah, I think you're right on. I mean, with case reports going so far back, it must have been there before. But I think our clinical skills and awareness for this entity are getting better. And also kind of the concept of diagnostic overshadowing, not attributing everything to the diagnosis of Down syndrome is changing. So we're now looking for reasons for why this might be happening and not just kind of accepting it.
Yeah, that's so interesting. And it's so great to know that we're still learning so much about what it means to have Down syndrome, and so many things that we once thought was one thing, but now we're realizing that, wait a minute, this is something that could potentially be treatable. But before we get to those options, why do you think this is something that happens in people with Down syndrome? What are some of the thought processes behind that?
Well, that's a really tough question in some ways. There are things we know, and there's still a lot of things we don't know. So from the research you and I and our international group have done together, we have found some differences in people with Down syndrome who have regression compared to people with Down syndrome who don't have regression. So, for example, in some of our research, we found differences in the number of stressors that people with Down syndrome who have regression had even before this regression happened. So, maybe that's part of it, that there's some kind of stressful event that kind of precedes this regression.
And is it something that happens at a particular age? Like, are there 2, 3-year-olds with Down syndrome who are having regression, or is there a particular age that we typically see this?
Great question. The average age is usually around 17. So it's kind of later in childhood and young adulthood. And back to your question about kind of early onset Alzheimer's disease, this is different than Alzheimer's disease. And this is different than autism. This is kind of its own unique thing.
Yeah. And I think, as you mentioned, that age, that late teen, early adulthood, there's so many changes that are happening in every life, but particularly in somebody with Down syndrome. I recall when I was going off to college, or when I got married, like, these were big life events for me, but probably even bigger life events for my brother, who was so used to routine, and that routine getting mixed up. And I know that we've all talked about, is it possible that some of those general life stressors that happen around those ages could trigger this in susceptible individuals? Would you agree with that thought process?
Yeah, when we compared kind of our data between those cases who had regression and the controls who didn't, you're right. There were many more stressors in the ones who had regression, and some of the key things were changes in school, employment, work settings. So that really, those kinds of changes for certain people really can have a big impact.
So what should a caregiver do? Like, what would be maybe some of the things that they may start to see first and start to recognize as maybe being a little bit off? Maybe their primary care doctor may not know that there's something to be concerned about. What would a caregiver, what should they start to notice? And when they start to notice, what should they really do at that time?
Yeah, that's a great question. So from our data, we looked at 28 features of regression, and that we compared between the controls and the regression cases, and we showed really clear differences. So in that paper, we have a really simple 28-item checklist that if people are wondering if their loved one has regression, they could take this to their primary care physician and look at this checklist together to see how many of the symptoms really are there. We also want to think about other things that could look like regression. So thinking about co-occurring medical conditions that could kind of mimic or exacerbate regression, and just checking with the primary care doctor to look for those kinds of things too.
Yeah, I agree. It's so important anytime we see behavioral changes, right? And people that we take care of, that we make sure that they've been following those healthcare guidelines that have been put in place, because there are so many medical issues that could perhaps masquerade as something like this. So that's a great reminder for our families as well. But let's say we get somebody, we clearly feel like they have regression related to the Down syndrome, as we've been talking about on this podcast. What are some of the treatment options that have been tried, and what has been maybe shown to be successful in bringing kids and young adults back into hopefully some semblance of being able to continue their lives again?
Yeah. So as you know, our group has continued to look at the cases we have over the past few years, and we've been looking to answer just this question. So amongst our international sites, and we have 7 sites, we've collected a little over 50 patients with regression, and we've tracked them to see what types of management they get just in a natural clinic setting, and what things are sometimes helpful or sometimes less helpful. So the types of treatment that have been tried, often the first thing that's tried is different psychopharmacology, so different psychiatric medications. And sometimes that can be helpful, sometimes not. And with psychopharmacology, there's often a lot of kind of trial and error to find the right medication or the right dose. So that's a pretty common treatment that's been tried. Some patients have tried other things, like there's some good research about immunotherapy out of Duke, looking at IVIG, IV immunoglobulins, and other medications. And then some other things as well, like electroconvulsive therapy, and even kind of newer things like TMS, transcranial magnetic stimulation. So there's a pretty wide range of things that have been tried.
So it sounds like probably for many of these patients, it might be something that a primary care provider would probably refer out to other specialists, maybe psychiatrists or somebody to help to manage. Would you agree? Like this might be something they would need to seek a specialist care?
Yeah. And I was thinking that as well. Even though you and I have seen cases of this, and a lot of people in the Down syndrome community have seen patients with this, most primary care providers might not have, just due to the nature of it. So one thing people might also look at is finding a Down syndrome specialty clinic near them, either on the National Down Syndrome Society website or the Down Syndrome Medical Interest Group website, because those people would have either seen cases or be connected with other doctors like you and I who could help guide them a bit. Yeah.
Yeah. And I guess that's kind of leads into this next question. So is this an area that you would say, hey, we're done, we know everything we need to know? Or would this be an area that you're thinking there's a lot more to learn? And if so, what's being done in this time?
Yeah, there's actually a lot of research that's needed in this area. The research we've done so far is really kind of natural history research, describing what we do in clinic, what we see in clinic. But there's many more opportunities to kind of look at how we diagnose this, how we define it, what the mechanism, like what the pathophysiology of all of this is, not only to find cases, but maybe even eventually get to preventing them and kind of helping this from happening to future teens. So yeah. I think there's a lot of research in this area.
Yeah, and I think, when you were talking earlier, Dr. Santoro, about the consortium that we've put together as part of a multi-center, multi-nation, actually, groups that are looking into this. And you said, we had 50 patients, which I suppose somebody on the outside might say 50, that doesn't sound like a lot, but that's a huge number of patients when you look at the literature that's out there, because this is a relatively rare condition. And yet being able to pool all of this information and be able to get this information out to providers, I think has been so helpful. Well, are there other areas that you think would be helpful for families to be able to understand this more? Do you feel like we've covered this topic pretty well today?
Yeah, I think that's a really good summary. I would say if anyone is concerned or has questions about this topic, I would first look at that 28-item checklist. The main things really are changes in adaptive function, so how people are kind of interacting with each other and doing their activities of daily living, changes in their cognitive executive function, like planning activities, doing procedures, learning, and then things with motor symptoms, like having different tremors or new movements or having trouble starting movements. So those are really the key things. This is a pretty unique entity once you've seen it. Yeah.
And I'll put a link to that checklist. But where would you say again where families might be able to find that? I'll put that into our show notes.
Yeah, it's published online in our paper in one of the supplements, and I can share the link with you for sure.
Perfect. And then for our families, I hope this was something that was really helpful for you to understand more about this condition. Dr. Santoro, I really appreciate you taking the time to join us and explain a lot more of the intricacies of this diagnosis with our listeners. I think this is going to be super helpful for folks that are out there wondering about this, because we do. I'm sure you do too. We get questions about regression now as more and more people know about this entity. So thanks again for joining us.
Yeah, thank you so much for having me.
Of course. And for our families, for our listeners, if you have any questions or anything else that you would like us to discuss on this podcast, please do reach out at Down Syndrome Center at chp.edu. We'd be glad to talk with you further. I've had so many emails recently. It's been great. This keeps our podcast going. It allows us to know which topics you would like us to address. So please do not hesitate to reach out. Be glad to hear from you. But until next time, bye-bye.